experience. Yeah, so yeah, the recording's just started there. Thanks, Michelle. So yeah, our topic today is lived experiences of multiple long-term conditions. And for our opening talk, I'm very happy to introduce Mrs. Pauline Mountain. So Pauline has her own lived experience of multiple long-term conditions and also that of a family carer for somebody with multiple long-term conditions. She's a strong advocate for patient and public involvement in research and has extensive experience in this field. She's contributed to various PPIE advisory groups at both regional and national levels and has led masterclasses for engaging patients in research. She was previously a carer governor and elected lead governor at Lincolnshire Partnership NHS Foundation Trust and has been awarded an MBE for her voluntary services within the carer field. Currently, she's a member of the Community Voices PPIE panel for NIHR ARC East Midlands, of the NHS Lived Experience Co-Production Group. There's also a trustee on the Health Watch Lincolnshire charity, where she co-chairs the Health Watch steering group, and is a trustee on the Cardiovascular Care Partnership charity, which is affiliated to the British Cardiovascular Society. She's also the founder and chair of Hearts of Positive Energy, or HOPE, which is a local support network for fellow patients and carers. And she was one of the 50 inaugural Health Service Journal patient leaders, which recognised outstanding individuals whose personal experiences have led them to instigate change in healthcare, and as a result are shaping healthcare. Thank you very much, Pauline, and I'll hand over to you now for our first talk.
Thank you. That makes me sound very grand, and I'm not, I can assure you. I am very much me, feet are very firmly on the ground. Yes, I am Pauline. And thank you for that introduction. And I feel quite honoured to be here because obviously a lot of people are doing a lot of very, very good work, and all I seem to do is talk about it. So thank you for inviting me to come along. I'm going to give you a bit of an overview, and please feel free to stop me as and where and when. I don't like the death by PowerPoint, so I really do wish I was in the room with you. I have been in a few just lately, which are nice, but yes, I'll start the PowerPoint in a second. I think one of the things I wanted to say is that we all get up in the morning with our own objectives, and we sort of set them for the day, and sometimes with if you're in work, you set a standard of, you know, how many things can I fit in before I get out of the door or walk into your office. If that's been through COVID, it's probably been from the kitchen to the next room, or, you know, get in your car. Living with a long-term condition, that might be very, very different, and it will differ from day to day. So please, you know, do bear that in mind, that often, you know, head rules heart, or is it heart that rules head? It can flip in a moment. So without further ado, I will attempt to share my screen and see what happens. So do bear with me. Here we go. So I've entitled my talk today of Hearts and Minds and called it I'm Fine. Multimorbidity, which is one of the things that we are talking about. And I've set these as probably objectives for today. Well, what is it? It's a great big long word. And what does it mean? Well, from a patient point of view, multi means a lot. I'm afraid morbidity means, oh, it's not very good, is it? So how does that make me feel as a person when that diagnosis is delivered? And can we create the balance and understanding? And my fourth one is words really do matter. So MLTC, let's move on. I put this slide up because I think it's really interesting. It's about a debate and divided opinions. We talk about health so often, and we only recently, I believe, have pulled in the social determinants of health. And again, I think it is starting to divide people and make people stop and think about what else is there surrounding our health And, you know, at the moment, yes, we have got lots of crises going on, let's say, within what is affecting our health. And without being political, we go into saying, you know, we want this, we want that, we want the other. But, you know, what is it that we can do? How can we help ourselves and each of us be supportive of one another? I suppose, where have we come from and where are we going is something that I think we can probably look back to then look forward. And I'll hope you will embrace the following slide. This is evolution. This is where we believe we came from. We came from a Neanderthal man and we moved ourselves forward. And I'm going to say it makes me, yes, I think it's quite, if we were in the room, I think we'd have quite a debate about it, in the fact that we've managed very, very well, and we've gone out and it looks like we've hunted for ourselves. And then, dare I say, there's consumerism come along, and it's put consumerism in our hands and said, right, get on with it and see what happens then. So maybe we've got to take some onus of, it's not all about us, it's about what can we do, and how do we develop from where we were to where we are now, and how do we move forward? And do we need to connect more effectively with that wider community? Somebody has put in the chat bar, I've just picked up, Amrit, which one do you personally prefer, multimorbidity or multiple long-term health conditions? I don't like the word multimorbidity. As I say, I think it conjures up two words. I'll go on to tell you a bit more in a moment why I think it conjures up a bit more about words. So if you'll forgive me, I will answer that one in a moment too. But thank you for asking. Moving on, I would like to now sort of tell you a bit more about life and how I came to be sort of embracing this aspect of life. Life in pictures. So the black and white picture is, I'm the baby there. This is where I started, where most of us started, I think, as life as babies. And you might think I'm sat there on my mum's knee. Well, I'm not. That was my auntie, and actually not my true auntie, but my mum is at the side of me. Now, either side of, sorry, she's at the side at the back. Either side of me are my twin sisters, and either side of them are my twin brothers. So yes, I had two sets of twins, and then I was the odd one out. And I think I've probably lived up to that name in more ways than one, because what you can't see below that picture is that I had what was called a kicking splint on, because I was born with a club foot, and quite a serious one, because it was turned completely round. Now, I was very grateful for a very innovative young doctor who decided that, you know, he was going to make a name for himself, and he was going to do what he could for this little girl, this baby that had this club foot, and he did. His name was, sadly he's passed away now, but his name was Mr. Gordon Kenneth Rose. And Mr. Gordon Kenneth Rose used to come out and see me before I went in for an operation. He used to send me a Christmas card every year. That's how passionate he was about ensuring I had my foot looked out for. However, as my life moved on, and I was in and out of hospital for most early parts of my young life, let's say, obviously that changed, and you know, I didn't know much about that. Obviously my mum dealt with that, but she obviously was my carer, hence why was there that disparate parting between us. She was, you know, she had two beautiful twins. She was quite proud of those, and then suddenly she had this child which became a bit of a nightmare. Yeah, because I was probably demanding in all sorts of ways. Now, moving on from there, obviously I moved on through my childhood and I didn't let anything stop me. I carried on and did things, etc., etc. And I worked, I got on with life, and that was it. I met and married later on in life, and divorced, I'm afraid to say. But one of the things, I have 3 children altogether, but Amy there in the top left-hand corner, where I don't know which is where you're looking at it from my left, is Amy holding on to what is her stepdad, Gordon. And Gordon had heart failure, which is another word which I think is similar to that multimorbidity. The heart failure, to me, is 2 words. The heart keeps us alive. Failure means that it's not working very well. Now, I'd lived with my dad, who's in the centre, who'd also had problems with his heart, but he got rushed into hospital and he got fixed and then back out again. So what was the difference? I didn't understand it, because, you know, why couldn't they fix Gordon like they'd fixed me? Why didn't they fix my dad? So why couldn't they fix Gordon? And nobody would give me answers. What was it about heart failure that was so different? And Amy, and the reason she's hanging on to Gordon there is that when I say we met and we married, that was where it was love at first sight. They just loved one another so greatly. But there she is in the bottom corner. She came to us when she was just 8 and said, I know what I want to do. We said, what? And she went, would you mind if I was a doctor? And we went, oh gosh, no. Mind you, that's going to be a life of poverty for us. And he said, oh, she'll change her mind. Well, as you can see in the bottom corner, that's her graduating. I just picked her up this morning from a night shift in A&E. So no, she never did change her mind. So moving on, and I don't want to talk any more about myself or my daughter. I want to understand, or help understand a little bit about why I became more involved with these words and this about heart disease, etc. This is what I lived with as a carer with Gordon. And I'm not going to go through all the things that he had, because they were so multiple and they were just words. They were just different things that kept building up and kept happening. And they were just there, and he didn't look any different. There was nothing dramatic that was happening. You know, that somebody said, well, he's had a cabbage. Well, you know, I go to the greengrocers for a cabbage, and yet, you know, they were talking about all these strange things, these words. They told us that he had an enlarged heart. Suddenly I thought, great, he's a Yorkshireman. Yorkshiremen don't have big hearts. Maybe I found one that has. But all the things they were talking about were about heart failure. And at the time, this was not mentioned. These are a few of the other conditions that he had. And he was in and out of hospital and in and out and so on and so forth. And one of the times he had, he was strapped up, he had a thing strapped around him, and he had something that he had to monitor, and then went back and handed it in, and that was it. And then we were called into the consultant's office, very well remember it. Well, I remember going into the office, and I do remember those 2 words that are at the bottom that say sudden death, and that's it. And I drove home from Lincoln County Hospital to the village that we live in, which is 14 miles out of Lincoln. I don't remember that journey. I don't remember until we walked into our lounge and sat on the sofa and sat down and both cried because we didn't know what that meant, because sudden is what it says, it happens. Death is final. What did it mean? We phoned our GP and said, what is this? He said, just come in. And he explained. So out of all of this is what I'm saying. The hearts and minds, they work together. And Gordon looked well. Gordon looked absolutely well. But if you think about it, he was full of Botox. He was full of fluid. I'd say Botox because that's a bit flippant, isn't it? But I wasn't. I was running on some sort of adrenaline. I'm not really sure what it was, but I was keeping going. I was running work. I was running Amy back and forwards to school. I was running my own business by this time. Yeah, I changed my job because it was so stressful. Gordon said, why don't you do what you've always wanted to do, have a little cafe? Oh yeah, that was great. We did do that. We thought it was going to be okay. What we didn't realize was that being a carer, yeah, it's full time, isn't it? We put all our savings into the cafe that I thought was going to be my retirement. No, you can't just hand a sick note into yourself, can you, very much? So the hearts and minds, yeah, there was lots going on there. And I know there's a clinical aspect to that, but that is not joined up altogether. Yet there is vascular dementia. There is an awful lot that we can do to build and bring together those things rather than just saying what, you know, you've got X, Y, or Z. So what happens when you ask a heart failure patient how they feel? When I first came into doing this, it was because Gordon was asked to give a presentation. And Gordon was a soft, gentle, mild-mannered man, and no more could he deliver something like this. He would shy away from anything like this. So I was asked if I would do it on his behalf. And this was many, many years ago. So I would keep asking him, and all he would say is, I'm fine. And so therefore I did become a speaker on his behalf, but I had to put those words, I had to make them mean something for the audience that I was speaking to and with, and help, you know, people understand. And in reality, this is what he was feeling. He was fearful for the future. He didn't want to let that out to me because I was his wife, and, you know, he didn't want to tell me really how he was feeling. He was isolated because, again, he was here on his own, and I was running around and doing spinning plates, as they say. And he was needy, but he wasn't sure what it was he needed. And sometimes he got very exasperated with life because he couldn't do what he wanted to do even within his capacity each day. So I know this is a really busy slide, and I'm not going to ask for forgiveness for it, because it is about what goes on in somebody's head. And as I've put there, what it means to the individual with little or no choice, because he didn't have choice and I didn't have choice by then. But as the professionals, you do know those technological facts. You have the access to the knowledge, and more importantly, have the ability to understand the implications and either separate or group together the important bits. But as the patient, I live with a variation of these thoughts on a daily basis. It is like being on that roller coaster of emotion. And it really is how I am feeling right here, right now, that truly matters to me. And it's all the other things in between, and all the things, you know, the breathing, the debilitating, the pain, the anxiety. For me as a carer, I have no clue what all these mean. When do I phone for help? When do I phone 999? I'm not sure. I don't want to bother people, but actually I am really not sure. You know, what happens? I'm frightened that I might lose my husband because it is my fault that I didn't do what I should have done. And they're all the things that are imbalanced. So I need help, but I don't know quite where to go. Part of HOPE stands for Hearts of Positive Energy, as Harry pointed out, but I had to do something that was positive, and trying to put things in some sort of way that is relative. And I'm not saying this is right, but it was, what does cardiovascular mean? What is multi-morbidity, as we say? What are all these collective things that come to the table? How do they represent my body, my life, etc.? Diabetes is probably one of the things that crept up on Gordon, and that was because he was drinking gallons and gallons of water. And suddenly, and we had a good diet, you know, we didn't overindulge, we didn't, you know, I was a caterer, so I knew, you know, the balance of food, but suddenly this crept up on us. So yes, choice and options, but, you know, some of the things I didn't realize that I had no choice about because it was too late. You know, this Gordon, as I said earlier, he'd had 40 years of it, and, you know, so there was lots of things that were happening that I'm afraid I couldn't change. Gordon only had one kidney that he was born with. It was congenital, so that was not going to change. But there are things that we can do ourselves. There is, you know, even just in the word of self-management and self-care. But within the ARC, I'm coming on to that, I might be flitting, but this is a whistle-stop tour. There are programmes that are funded by the ARC that are there within the multi-morbidity programme that have been funded. And if you're not aware of them, I'm sure some of you will be aware of them, some of you will already be involved with them, etc., etc. If you're not, I know that you can obviously link into them, you can follow them, etc., etc. Coming on to what I do now as well, I'm involved with patient and public involvement and engagement, and part of the ARC Community Voices panel. I am such an advocate for that, because without bringing those voices in, and I am only one voice, so you only hear one side of that voice, and from one angle. And as you well know, there are varied and many different sides. But being more involved and integrated and hearing different objectives, etc. And also sort of, it incorporates the EDI agenda that addresses the bias, both conscious and unconscious, in a variety of those public settings, that each study brings in. And you know, I've used the that wheel to say, you know, don't leave us out there, bring us in and let us have a voice, and let us be inclusive within that submission that you have. Bring us to the table and make us an integral part. Coming back to the multi-morbidity against the the multiple long-term conditions, it was actually the PPIE of Community Voices panel that actually said to ARC straight away, when it was before we even got the national title, we said, we don't like that. What does it mean? How can we change it? So again, within the ARC, we actually did have some influence, let's say, in changing that to become multiple long-term conditions, because it is a lot friendlier. So in answer to your question, that is our preferred. And yes, probably we've gone from changing from an acronym that we say we don't like to being an acronym. But anyway, there's an appropriateness in everything that we do, or try to. This is the ARC wheel, which you will see that PPI links in with everything that we do within ARC. It starts at the top and it moves all the way down and all the way through to the implementation. And again, it looks busy, but it works. It works the way through. So again, I'm going to ask the question, what happens when you ask a heart failure patient how they feel? If you get it right, or if you, I can't say right really, because there are many, many ways and every day is different. But if you get it nearly right, it's, I really am fine. And you get a little bit more from that. And it's, I'm feeling reasonably well, thanks, Doc. And I'm involved and included in my care. And now I'm feeling more confident and supported. And I'm educated in what I need to know and when I need to know, and how to access the right people, info and services, and more importantly, when I need it. Coming back to my social determinants of health. So can we influence a nation? What if we use healthy and varied communication methods, or is there something else? There's always a what if. So I believe living with multiple long-term conditions, life can go on with support. Thank you so much for having me here today. Thank you for listening. And if there are any questions or comments, I'm more than happy to answer. Just before I go, Harry mentioned that I'm part of this. There is an invite. I think you're going to send it out after, aren't you going to, Harry?
Yes, that's right. Yes.
Yeah, I am actually organising this on behalf of Patient Day at the BCS conference on the 7th of June. So if you do want anything more, it will go out and you're more than welcome to join. There is an online presence, but you're also welcome to come along in person. So I'm going to try and stop sharing now, and if there are any questions, more than happy to answer. Thank you.
Thank you very much, Pauline. Yeah, thank you for sharing your story with us and those deeply personal insights. Especially, I think looking at pictures, it was, you know, just being able to visualize your journey was really powerful. So thank you very much. It's a real privilege. And if anyone's got any questions, as Pauline says, please feel free to either type them in the chat function or raise your hand.
One from Jerry.
Yeah.
Oh, you're a bit echoey.
Sorry, is that better?
Yes, I can hear you now.
Yeah. Apologies, because I'm on my phone and my computer because the computer audio is not working very well. So as a cardiologist, I was really disappointed to hear that Gordon hadn't been told that he had heart failure. And it reminds me of days gone by where euphemisms were used and people weren't told that they had cancer or they had a growth or something. And you know, I think we need to be honest and upfront with patients. But I was wondering how whether you might want to comment about how we should deal with telling patients they've got a very severe illness, you know, that usually does have, let's say, very significant impact on both quality of life and long-term outlook.
Yeah. What I didn't add to is Gordon did pass away. It is nearly 14 years since he passed away. This is why I carry on with the conversation now, because it still happens. So I think it's difficult, at whatever stage. And initially, with heart failure, I think I wanted everybody to know straight away what the outcomes were likely to be. But I did tend to change my mind significantly, because I think there are certain aspects of everybody's, I'm going to say, conditional journey that changes that, as I've learned along that way. That, you know, somebody said to me once, you're lucky you had your husband to say goodbye to, because her husband just died very quickly, very suddenly. And I said, really? I watched my husband change. I watched my husband go from a happy, vibrant man to losing his tenacity for life, for me having to, we used to say have people round, and his cognitive behavior, that's why I put the hearts and minds in, his cognitive conception of, you know, he would come in sort of 5 conversations later. Now that was okay for friends that had followed our journey, but people that were new introducing in didn't understand that, and they'd look pitifully at him. And Gordon was actually 15 years older than me, so it was almost like, oh bless. And it's like, don't pity people, stop it, just treat him normally. It's horrible. It's the same as dementia, isn't it? So I just want people to treat us in life as people. So I'm not really answering your question properly, am I? I'm asking you to treat me as an individual. That's what I'm asking you to do.
It was interesting. I mean, heart failure is, you know, obviously for many people such a debilitating condition that shortens their life, and you put up many of the complications that arose from his heart failure, including atrial fibrillation, etc. And I think obviously what we're interested in this meeting in particular is the aspects about the other multimorbidity, and we know that at least, you know, close to half the patients will have diabetes. And probably something I've focused less on is the psychological impact of the diagnosis, and not just the diagnosis, but then the actual physical link that you clearly put up, and something we should probably focus a lot more on, and how we support people in terms of their psychological health who have very severe illnesses that you know really impact in their quality of life.
Yeah, to me that is the most important thing. Clinically, things have gone working wonders, absolute working wonders, from all sorts of avenues right the way through. You know, we followed a pathway to try and get anything done. You know, we would look for anything. We went down to London to look for things. We used to go, you know, we had quite a close relationship with Richard Andrews, and say, what is there? What's new on the market? Please tell us. You know, we looked into stem cells. please, anything we can do, you know, but we didn't just sit back and wait. But that, yeah, and that in a way was why I set up Hope, because even just walking into a group where people were proactive, and when they walked through the door, we used to say, leave your condition outside, please. You come in here for 2 hours and you don't talk about your condition, you talk about life, you know. So whether you had fish and chips or egg on toast yesterday, talk about life. So yeah, it is about the psychological aspect of living with long-term conditions is important. Thank you.
Thank you very much, Paulina. It's that risk of depersonalization, isn't it, that happens through with clinicians, and like you say, just forgetting to connect, as you've said to me before, hearts and minds, and actually, you know, thinking of the patient in front as just purely as defined by their condition, and actually forgetting that they've got a story behind them. They've got all these, you know, all these moments behind family members and various other things, their own life. So it's remembering that element, isn't it, that can be lost sometimes in this complexity. And as we were saying, it's this sort of the multifactorial element, isn't it, that it's the physical symptoms, but also the emotional impact, the psychological impact, the impact on family members and carers, and sort of on top of that, trying to sort of navigate sometimes the medical complexities, understand the jargon, understand the science behind things, fear about the future, and fear about, you know, outcomes, and so many things to think about. Yeah, absolutely, that kind of so important to bear.
Very much horses for courses as well. You know, we do know that, appreciate and respect that your clinical expertise is there, but that when that sort of movement to being put into the right place to say, look, you know, these people are the ones that can support you. It's that recommendation, you know, that signpost forward that says, you know, look, if they'll, you know, it's like, oh, it's that recommendation. Well, yeah, that doctor said it was good, you know. And I think certainly from Gordon's point of view, he was an old person that still had that respect and that understanding. You know, it wasn't just well, I pay my taxes and, you know, that's what the job they do, so to speak. And I think, you know, we sort of, I just think we're sitting on a seesaw at the moment, and we need to engender that hearts and minds so much more into understanding that that's what we need. You know, it's not just take a pill and go away.
Absolutely, and as you say, sometimes it's, you know, there's the impact of receiving the information, and that actually the questions and things don't come to mind straight away, and it's things that crop up later on when you go away, the difficulty that patients may have in articulating what's going on in their minds. And so the importance, I think, of revisiting, and as you say, of signposting them to, you know, appropriate organisations as well, or just that follow-up really beyond just that limited consultation time, isn't it? Yeah, absolutely. Thank you very much. Thank you.
Thank you.
And has anybody else got any other questions at all? Feel free to put any comments. I can see Shukrat here has posted. Yeah, thank you very much. I appreciate your points for clinicians on better communication and checking that they're on the same page with the patient, and also listening what is really important, priorities for the patient and their carers, and setting the agenda for patient care. Absolutely. And sometimes the options for patient care are not so easy to choose from. Absolutely true, and very, very much so in the case in this particular field, isn't it, of navigating the complexity of multiple long-term conditions. And yet open discussions absolutely are the way forward, I feel. So if anybody else has got any other questions or comments at all, questions for Pauline, or any other comments they'd like to make.
Thank you.
Okay, thank you very much. Thank you.
Thank you.
Thank you. It's a real privilege to hear your story. Thank you very much. And so now we've actually got one of our academic GPs here. So we've got Dr. Kate Woolley, who's going to be talking about the clinician perspective for the lived experience in multiple long-term conditions. So Dr. Kate Woolley is a GP actually based in Nottingham. In addition to this, she's also an NIHR in Practice Fellow here at the Leicester Diabetes Centre. Her research is in the area of patient education and lifestyle change in cardiometabolic disease. She's also involved in multi-professional medical education with roles here at the Medical School at the University of Leicester, with the Nottinghamshire Alliance Training Hub, and also with the British Society of Lifestyle Medicine. So thank you very much, Kate. So I'll hand over to you now.
Thank you, Irene, and thank you very much, Pauline, for that really thought-provoking talk, and thank you for sharing your experience with us. I'm just going to start sharing my screen now. So hello everybody, as Harry said, I'm Kate Woolley, I'm a GP in Nottingham, and it's from that perspective that I've really come to speak to you here today and to talk, just give a practitioner, professional perspective on lived experience of managing multiple long-term conditions for a general practitioner. I can't claim to bring the level of personal experience that Pauline was able to share with us today. I get to go home at the end of the day, but I hope that through this talk I'll be able to highlight some of the issues that I've seen people in this group of patients with multiple long-term conditions, some of the issues I've seen them face, and also try sort of to introduce some of the barriers that might be there for the GP or the doctor in providing the best quality of care for the patient, because ultimately that's really what we all want, isn't it? So I'm going to talk you through a typical clinic that I might have with some case examples, because I think that will help to bring the subject matter to life a little bit for us. I'm going to talk about how the GP system is set up and the preparation we receive for the work. Woven through my talk are going to be some perspectives from other GP colleagues and also some context from the literature, so it won't be just purely my own perspective that you'll hear here today. I'm aware we've got a very varied audience. I've tried to make this talk understandable for all, but if you find that I'm using too much jargon or you feel that you'd like any clarification on anything, please just send me a message or raise your hand or just unmute yourself and let me know, and I'd be happy to explain a bit more. So 9 AM on a Wednesday morning, that's when I start my clinic. My first patient is Karina. She's 19 years old and she's had a recent diagnosis of renal failure and she's hypertensive. We made this appointment to review her recent blood results, check her blood pressure and potentially further titrate her medication. Her EGFR, which is a measure of kidney function, was 13 previously, and it has dropped now to 7 after her blood pressure medications were started. Just for people who may not be clinical, a normal EGFR is kind of above 70, and so a patient might be facing renal replacement therapy or dialysis once their EGFR gets as low as 7 or 6. So she's really not got very much kidney function left at all. When Karina comes into my consultation room, I ask her what she wanted to talk about herself. She says that she's completely overwhelmed by the current situation. She started experiencing suicidal thoughts, and she gets these every day. She wants to be referred to psychiatry to help her with these suicidal thoughts. She also thinks that maybe the reason she's feeling like this is that she's actually got an underlying diagnosis of autistic spectrum disorder. Her blood pressure is also still high and she needs a new sick note because the one that she was issued a few weeks ago has now expired. So there's a few issues here, clearly. The psychological and physical comorbidity is extremely common, as we've already kind of mentioned, and Karina exemplifies this. She has obviously her own priorities for the consultation, which were different to my priorities at the outset, but all of these things are extremely important. As I said, her kidney function is very low and it's important that we manage her blood pressure properly. And also having daily suicidal thoughts is extremely distressing for her, and we need to make sure she's got appropriate support with that as well, and within safe timeframes. I don't mind saying that managing blood pressure in someone who has already lost some kidney function as their blood pressure medications were started, and blood pressure is still high, might need to increase them further, but she's not got much kidney function left to play with. It takes me to the edge of my professional comfort zone. Of course, there's help available for this. Obviously, it's a learning need I can address myself. I can give one of the hospital clinicians a call or write to them, but working at the edge of my professional comfort zone is obviously more stressful than when working completely within it. There's also the personal and societal impact of multiple long-term conditions disrupting Karina's ability to work. It'll be, I hope that, she's right at the beginning of her potential working career, but she has had significant disruption to this through her recent health issues. I really hope that we will get her back into meaningful work once things are a bit more settled for her, but that's not a given, and it could really affect her well-being further if she's not able to rejoin the world of work. Someone's just put something in the chat. I'm just having a look. Oh, thank you, Pauline. So 9:25, I've managed to speak to Karina about the things that she's brought today, and we've made a safe follow-up plan, and I've arranged some time to properly explore the diagnosis that she's worried about, the autistic spectrum disorder, and arrange also appropriate psychological follow-up for her with the thoughts that she's been having. So we've kind of on to the next patient. Eileen is 85 years old. She's got chronic renal failure, CKD stage 4. It's only just stage 4. She's got an EGFR of 29, so compared to what the previous patient had is better. She's also got unstable angina. She's got poor mobility generally. She finds it difficult to walk, and she's quite frail. She's also got osteoarthritis of her shoulder. She's made the appointment today because she feels terrible. So for Eileen, her angina treatment options are limited because of her EGFR. When someone's kidney function is low in this way, they may not be able to, their body handles the medicines differently, and that might mean certain medicines aren't really suitable. She was told that she couldn't have any kind of intervention for her angina. We wrote to cardiology about the angina medications, and they'd advised to continue them despite the EGFR because they were helping her symptomatically, and they felt that it was a reasonable calculated risk to take. But then she had been admitted to hospital for something else, and the doctor who looked after her during that time felt that it wasn't a reasonable risk to take, and they stopped the medications. Since then, she's been in pain all the time. It's difficult to really tease out which is the pain related to the angina and which is the pain related to the osteoarthritis, because for Eileen, it's just all pain. And the osteoarthritis of the shoulder is in a similar sort of area, so she really struggles to tell the difference, even with a kind of really careful history. She's also been seen by 4 different GPs in the past 4 weeks, so she's feeling kind of pushed from pillar to post, and she's made several appointments because actually at the end of the day her problems have not been fully dealt with, hence why she's having to come back again. So in the case of multiple long-term conditions, as in this case, one condition often limits the treatment of another. Many specialities will have a single organ focus, and that might result in conflicting advice to the GP, which makes our life a bit confusing and also is difficult for the patient as well if they're receiving conflicting advice from different places. Similarly, guidelines are often condition specific, as are patient information resources that I might give to Eileen to try and help her better understand what she's going through at the moment. As you may know, the GP system is set up as 10-minute appointments with a sort of notional 1 problem per appointment. That's for a good reason, because if someone wants to talk about more than one large issue, then that means we have to cut corners, and that may just simply not be safe. I would always try and fit in as much as possible that the patient wanted to talk about, but it's based around that kind of proviso. But that's unrealistic for someone like Eileen, whose one problem is really contributed to by lots of different medical conditions, and it's really about optimizing all of those medical conditions simultaneously to get her the highest level of function that she might be able to have. and sort of the highest quality of life for her. There's pressure to offer appointments within given timeframes, so within 48 hours, for example, or on the day, and that means, and also the need to offer extended hours means that the same clinicians cannot be in the surgery all of the time, and that means that the continuity can often be disrupted. That therefore, the first few minutes of the consultation, when someone has a complex history, like in this case, is used in the clinician simply trying to get up to speed on what's happened before, and that means that there's even less time to talk about what's important to Eileen. In this case, Eileen had multiple long-term conditions, but each of them kind of fell below the threshold at which a specialist might kind of take them on. So whilst each individual condition was below that sort of referral threshold, cumulatively, that had really significant health consequences for Eileen. So at 9:45, I've managed to speak with Eileen about the problems and make a bit of a plan to go forward and arrange some follow-up so that she can feel like she's being looked after with just one person now, rather than having to see a whole range of different people who don't really know her. My next patient is Ali. He's a 70-year-old gentleman with atrial fibrillation, non-alcoholic fatty liver disease, Crohn's disease, type 2 diabetes, and he's been called in for a medication review. He's feeling frustrated because his appointment was at 9:20 and it's now 9:45, understandably so. But it's also tricky because I don't think that those two previous patients, I think that the extra time was needed to help sort their problems out safely, or to sort of make a plan for them and make sure they had appropriate follow-up and they were going to be safe and that we were going to do something for them. So it's really difficult. Because I don't like calling a patient late, but equally I think that time was needed for the people who had come before. In the medication review, Ali says that he's stopped rivaroxaban as it made him feel sick, and so he's not been having this medicine for 6 months. For those who may not be clinical, rivaroxaban is a blood-thinning medication that when someone has atrial fibrillation or an irregular heartbeat, they may be started on this medicine to reduce their risk of forming a clot inside their heart, which ultimately could become a stroke, could lead to a stroke. So obviously by stopping this medication for the past 6 months, Ali has been at risk of having a stroke. He doesn't think the medicines are working, which probably suggests that he hasn't really had a good explanation as to what the medications are supposed to be doing, because actually for many of the medications he's taking, their purpose is to reduce his long-term health risk rather than to make him feel better day to day. There will be some that are for making him feel better day to day, but a lot of them will be about modification of long-term health risk. And so he won't necessarily feel them working, but that clearly hasn't been explained to him properly, almost certainly because there's been insufficient time to do so. Polypharmacy, so that taking lots of medicines is very common in patients with multiple long-term conditions. That makes side effects from the individual medications more likely because they may interact with each other as well as with the patient's system. And in this case, patients may then stop important medications because of the side effects that they're experiencing. When the appointment is too short to offer the proper level of explanation to the patient, then this is just compounded, because it's completely understandable that a patient wouldn't want to take a medicine that they don't really know why they're taking it. Health literacy is a factor here. So those are sort of skills that allow a person to find out health information and use it to improve their health. Low health literacy predisposes to having more long-term conditions, and improving health literacy and giving these patients the knowledge and skills they need to manage their health is really important in improving their long-term outlook. So this is even more important in the context of low health literacy predisposing to multiple long-term conditions. As I mentioned, late running is inevitable when cases are so complex, and that's stressful both for the GP who's running late and wants to give a good service, and also to the patient who is then being called late for their appointment, might need to be somewhere else, and also for the patient who is in the doctor's chair for 20 minutes, knowing that they only had 10 and feeling perhaps guilty for having bothered me for this long. As Pauline said, I don't want to bother the doctor, but they feel guilty for having taken that long, but equally they feel that they really, really need this time as well. And it's really distressful for everyone involved. So my clinic proceeds. I won't give you any more details. You've got the idea. Then 2 p.m. I'm called for a home visit. Yvette is 79 years old. She's got chronic obstructive pulmonary disease. She's got cor pulmonale, polymyalgia rheumatica. She's wheelchair bound, and she's got a history of deep vein thrombosis. She had a clot in her leg a few years ago. She completed her treatment and then stopped the anticoagulation because there was no reason to continue it in the long term. Was there a question? So she's no longer on any kind of treatment for DVT. But she's called today because her legs are swollen, as is normal or can happen quite frequently in someone with cor pulmonale, but one is substantially more swollen than the other. Another DVT is a realistic possibility. On this occasion, the system works. I'm able to get her an appointment for a scan the same day, and I can arrange some ambulance transport for her to go to the hospital to have the scan done. But she makes a competent refusal to go. She feels that while she understands what a DVT, a blood clot, is and what it means for her health, i.e. if it were to travel to the lung, then it would make breathing very difficult and could even lead to her death. She feels that actually she really doesn't want to go to hospital. She doesn't want to get the ambulance because she feels they don't manage her wheelchair very well. She would rather wait for a friend to take her, but that might be a number of days later. So she says that she won't go for the scan that day. Obviously, I have a conversation with her around the risks, and she understands the risks, and so I respect her point of view about how she wants to manage it. And I arranged a scan a few days later on the day that her friend could take her, because that was the safest thing that was also agreeable to her as well. But ultimately, patients with multiple long-term conditions do have to attend multiple and frequent hospital appointments, which may make them reluctant to accept further care, even when it is clinically indicated. They may feel that they've been at the hospital far too many times. It's a pain to go to the hospital. As with Yvette, she felt that her wheelchair was an issue about being able to go. She also this ultimately led to a divergence of my priorities versus hers, and also obviously we were able to resolve that through a conversation to make a satisfactory solution. But it is worth bearing in mind the number of appointments these patients have and how that might affect their ability to accept further care in the future. So I just talk a little bit more now about the way GP systems are set up. As I said, the clinics are based around a 10-minute appointment. Straightforward cases might also be streamed to the nurse practitioner. So in the past, potentially, I might see more people that had things like tonsillitis that I would be really able to see and treat and assess safely within probably even 5 minutes. And that leaves a few extra minutes to give to these more complex patients who need a little bit longer to really ask the right questions and give the right explanations. However, when these less complex cases are siphoned off, that means that everyone I'm seeing is really a more complex person that needs longer than the 10 minutes. It's very difficult to manage multiple long-term conditions safely and also maintain the relationship by communicating well with them and giving a person time to speak and the explanations that they might want in that context. In many cases, long-term conditions are managed by nurses as well, which is good because they may have a longer appointment and it does allow for a bit more explanation and discussion, which is really important. But that might, if the GP isn't mindful of it, it could lead to the GP actually de-skilling in managing long-term conditions and then only being brought in to review the most complex patients that the nurse doesn't feel happy managing on their own. As I said, the loss of the named GP system over recent years, which does mean that more appointments are offered in a shorter time frame, but it means also that there's less continuity of care, and more of the proportion of the consultation is being used up simply to understand the case. And the inability to do a good job with the resources available, as I've sort of explained, is detrimental to patient welfare, which is everyone's priority, but it's also detrimental to professional satisfaction, and this contributes over time to burnout and people leaving the profession. I'm just going to speak a little bit now about the sort of GP training, for anyone who's not familiar with it, and what training we receive prior to undertaking this work. So GP training is 3 years on top of the medical school degree, and then 2 foundation years. In those 3 years, we usually do 4 or 5 lots of a 4-month non-GP rotation, which might be in hospital or somewhere else in the community. They might cover things like acute medicine, obstetrics and gynecology, paediatrics, psychiatry, palliative care. So all things that are really, really relevant to general practice, but not necessarily to multimorbidity, to multiple long-term conditions, sorry, Pauline. Apart from perhaps acute medicine, there might be some multiple long-term conditions management there. The final year of GP training is purely spent in GP. And then we have a multiple choice examination and a practical examination. The multiple choice examination is normally in year 1 or 2, and then the practical examination in the final year. So that during COVID, it was that we had to send a whole load of videos of us managing a case in 10 minutes. And then in the pre-COVID, and hopefully again in the post-COVID era, you have a simulated clinic of 10-minute appointments, and you have simulated patients presenting. But as you can imagine, because it's an exam, they will give you something that you can manage in 10 minutes. So ultimately, the assessment format is extremely focused on the 10-minute consultation, and we're not really given much opportunity to be assessed in managing multiple long-term conditions. Healthcare of the elderly is not a mandatory rotation. This is not an area limited to elderly people. As I spoke about Karina, she was only 19, but you might find that you develop more of the competencies related to managing multiple long-term conditions in an elderly care rotation, but that isn't mandatory within GP training. And then there's not necessarily that much on deprescribing and other multiple long-term condition related competencies in GP syllabus. So this is a quote from a GP colleague. I asked, I spoke to some colleagues and said I was giving this talk today and what they would want to say around managing multiple long-term conditions. And they said it's getting more and more common, it's getting harder and harder to sort, and the time we're allocated and the training we receive isn't keeping up. I want to finish on a somewhat more positive note, though, of sort of areas I've thought of that might warrant further explanation to improve the situation. Hopefully, during the course of Pauline and my talk, we might have inspired you to think of other areas that might be helpful to explore as well. But things that I came up with were guidelines and patient resources with a multiple long-term condition focus, alternative models of GP care that better suit this population, determination of competencies specific to multiple long-term conditions and incorporation of this into GP training, and interdisciplinary secondary care clinics to reduce appointment burden. I know that lots of those are starting to spring up now, and that's really great, so that people can take a sort of multidisciplinary, interdisciplinary approach to a particular medical problem for the patients with multiple long-term conditions. So thanks so much for listening. That's my email address there if anyone wants to get in touch, and I'm happy to take any questions now if anyone has any. Thank you.
Hello, I have one question then, if that's okay. So I'm going to be doing a talk later with a PhD student around self-management of multimorbidity, and historically I've done work around diabetes self-management, and the pathway for referral is quite clear there. What do you do? Is there multimorbidity multiple long-term condition self-management programs that you refer to currently, looking more holistically rather than with a single disease plus comorbid or single disease focus? I was just wondering.
So I'm not aware of any programs that I can refer to regarding management of multiple long-term conditions. I guess that type of program might take more of a symptom focus, so much as you might have for other health conditions as well, but maybe thinking about what the patient's symptoms might be and when their symptoms are increased, what they can do and what conditions those might relate to. But I think it would be very individualised, because each patient with multiple long-term conditions has a completely different range of multiple long-term conditions, as as exemplified in the talk, and also will have a completely different range of symptoms. So it might be about helping the patients realise, have a bit more awareness of what symptoms mean what and what they can do in different contexts.
Yeah, because I think the pathway, for example, for diabetes is quite clear cut, isn't it? There are programs, but it's that kind of more holistic, complex self-management that I think we're thinking about in research. And I was just wondering how that sort of plays out currently, but
not very much currently.
No, that's what I thought. Brilliant. Thank you. And that was really interesting, actually, because it's not often that you hear so much detail from the GP perspective as well. So that sort of like pathway and experience was good to listen to. So thank you.
Thank you. And I can see someone's put in the chat, what's HCOP from my slide about GP training. That stands for Healthcare of Older People.
Thank you very much, Kate. Yeah, like Fionn said, I think sort of seeing that timeline there just kind of makes you realise how quickly time passes, isn't it? And how easy it is to, you know, with late running and things taking up so much longer than you expect. And yeah, absolutely. I think it was really great to see that really brought that to life, the actual timeline of the clinic. And yeah, the self-management, I think you're right. It's so difficult, isn't it, in a multimorbidity context to I suppose I wonder if the answer is that it's, like you say, symptom led and sort of focused on broader goals and broader outcomes, rather than condition, you know, like group clusters of multiple long-term conditions, but rather than more in terms of the goals of rehabilitation, whether that's, you know, various from a symptom perspective. So yeah, I think that's that would be an area to watch, I think, in the future. But as you say, I'm not aware of any programs at this point in time either.
Sorry, I think Shukrat's just put in the chat, how do I deal with balancing patients and priorities and the clinicians? So it's a tricky one. Often it means running late, as I sort of said in the chat. What I tend to do is I know before the patient comes in if there's anything specific that I wanted to get out of the consultation, and I also know how urgent that is, because some things could be deferred a couple of weeks without any particular detriment to the patient with respect to my own priorities. So I could always make a follow-up appointment if the thing I wanted to talk about was not necessarily that urgent for today. When a patient comes in, the first thing I'll say to them is, what do they want to talk about? And I'll let them sort of list all the things that they want to talk about as well. I'll then try and triage those things. So things that I perceive might actually be dangerous, then obviously we will talk about today. Things that might require longer and a more full discussion, but are not necessarily that urgent for today, I'll try and explain that to the patient and sort of say that, you know, it's in both of our interests that we make a dedicated appointment just to talk about this, so we can assess it fully, because it's clearly something really important, and if we try and squeeze it in today, then we won't do a good job. And then I'll make them a follow-up appointment to discuss that problem specifically. So yeah, I'll try and make sure that I've heard all of the priorities, and then using that appointment and subsequent appointments if needed, make sure that there's that the patient understands that all of those issues are going to be dealt with within a reasonable time frame. Pauline.
Yeah, I just wanted to say thank you, Kate, for, you know, bringing that GP perspective, because if you think about the patient and you know, their loved one with them, you are their first point of contact. And yet it is becoming more and more difficult to get that face-to-face with with yourself, your GP. And I think that was, and I know Jerry asked me, you know, about Gordon, and I didn't put it in my presentation that Gordon passed away 14 years ago this coming June. And the reason I didn't, because it could easily dilute the impact of what I'm saying in the fact that, well, you know, that was 14 years ago. But the fact that the reality of what I'm saying, I think is you've just identified it there, that everything that I'm saying is probably more enhanced now than it was then, because we didn't have what we call multimorbidities then. It was comorbidity. So Gordon would have heart failure, but there would be, you know, he'd have something else that went with it. So it'd be a comorbidity. So his something else would creep up. But now with multimorbidity, there is such a huge, and you've just identified some of the areas and the age difference now of where multi-morbidity or multiple long-term conditions, it's just become so vast in where it is and how it is, that how is the management going to be identified really and almost funneled into that individual? How do we do that? How do we get it to me as a patient? Because rightly so, you can't give to, you know, 20 minutes, as you say, you've got 10. You can't give me 20 minutes and every other one, because there's not that expectation. So I think there has to be, as I'm saying, there has to be some onus on us. How do we do that from this side? What is it that we have to do to make us a little bit more responsive and responsible? And, you know, I have some thoughts, but, you know, that has to be spread. There has to be almost a spread and adoption, as well as, you know, and us working together, because otherwise we're just going to keep coming. I hope I'm still here in 14 years time, but, you know, 14 years from now, I'm going to be saying, well, actually it was, you know, it was 30 years ago, it's 40 years ago since Gordon passed away, and there's still no difference, because that's what we don't feel as if we're moving on from. Does that make sense?
Yes. And I mean, I think, thank you for those comments. I think as we spoke about before, essentially a lot of the issues that we're coming up with in our different perspectives are actually the same problems to be addressed, but it's just told from both a clinician and a patient perspective. In terms of how patients could you know, empower themselves a bit more, I guess I could definitely see that that for the healthcare professional to help the patient understand how to navigate the system well, because certainly the issue with getting a GP appointment is real, and that's one of the reasons often that I do book follow-ups myself rather than asking someone to, you know, to make an appointment by reception, because I know that they might not get back to me otherwise. And equally, I might be more inclined to spend that, even if I'm already running late, I'll be more inclined to spend the 20 minutes rather than 10, because I know actually taking up another appointment is going to make it even more inaccessible for more patients to get in to see me. So it's that tension that I'm dealing with, and trying to make those decisions, because giving resources to one person always means taking away from another. So it's a really difficult decision to make. But I think patients understanding better how to navigate the system and where to get the range of different answers, because there are lots of other people potentially who could give the advice or the explanations that a person might be seeking from the GP, but patients haven't actually been let know about all the other resources that might be available to them. So helping patients navigate all of that might alleviate the pressure somewhat on both sides. There's also a question in the chat, thank you Shukra, about, is there a way to advocate for more time for patients with multiple long-term conditions from the start? Well, that's kind of one of the reasons I've raised it today. I would love to see more research into different models of running the clinic and provide the evidence that actually giving a longer consultation saves time in the long run, because things can be sorted out properly rather than putting a sticking plaster on it, and then the person ends up having to come back many times, which means more consultations are used, and it's also very detrimental for the individual with the multiple long-term conditions as well. So I think having more time from the start is absolutely where I think we need to go with this. And I guess we just need to have the evidence to be able to communicate that to the powers that be, so that the funding is there to run the surgery in that way. Yeah.
I'm just looking at the ARC funded projects. The one in the West is personalised primary care for patients with multimorbidity, primary care service improvement initiative. That might be one to look into and see what they're doing.
Thank you.
Yeah.
Thank you, Kate. Yeah, I agree. I suppose the question then that pops to mind, isn't it, that I've jotted down here, so is about the solution. So what is it that could perhaps make things better? What is it that might improve? I think one of the things that cropped up for me as well was this kind of interplay between the patients and clinicians' priorities and what's important. And a couple of times I remember when you mentioned about different clinicians coming in with different levels of calculated risk and what they felt was acceptable with that patient with heart failure, and with the angina, and the renal failure. So it's sort of competing clinicians' priorities as well, isn't it? And also clinicians and patients' priorities, like with the patient that you mentioned, with the high risk of DVT, but not wanting to go into hospital. I wonder perhaps if there's that element as well of as Shukrat has mentioned, what is that part of it to consider what's realistic, what's achievable, and tailor that towards actually what's actually important. And so, yeah, I mean, I wonder if that's one of the other things to, as part of, as you say, looking at new models of care and kind of understanding that it's not a case of one size fits all. There are some consultations that we do manage to do in less than 10 minutes, and there are some that take much longer. Yeah, there's that sort of understanding that those nuances, isn't it? Absolutely. So yeah, that we would hope that that's the direction that the future takes. And also really, I guess, the importance of getting the perspectives of patients, of clinicians, of how to kind of how to put this effectively into practice, you know, to understand those nuances and difficulties, the practical difficulties that might arise. Absolutely. So has anyone else got any other questions or comments that they'd like to make to Kate or from the presentations that we've had? Okay, thank you so much, Kate. That was really good. It was really valuable, I think, to have your insight and your time as well. Thanks very much for coming along today.
Thank you for having me.
Thank you. And so just so valuable, I think, to see Pauline's perspective and your perspective as well. And as you say, understand the common themes and actually how it seems like it's that interplay between managing these multiple complexities, isn't it? Multiple elements within time constraints. To me, that struck me as well as being really the common themes between the clinician and the patient's perspectives. And absolutely, yes. So now we actually have some time really for, we've got Kieran's just posted in their link for the project. So if anybody wants to have a look at the ARC multiple long-term conditions projects that are currently running or running in the future, there's a link there, so you can follow there for further information. And really now we've just got some time to sort of consider our thoughts and reflections, as we've already started to do, you know, from the lived experiences of multiple long-term conditions from patients and clinicians' perspectives. So really now I'd invite you to share with us any thoughts and reflections or any questions or any ideas for discussion that you might have from this point in time, and perhaps as we think about solutions in future directions. So feel free to share in the chat function, or raise your hand as well. Although that might be a little bit slow to respond, unfortunately, because my raise hand viewing option isn't coming up. So I'm getting that through secondary feedback. So yeah, so yeah, I mean, I suppose I'll start off really is thinking about, yeah, so possible solutions. So we've talked about changes in models of care in time and looking at priorities-led care. What are everyone's thoughts, do you think, on how could we make it better? What do we think would make things better in the future?
I was quite interested in Kate's thoughts around looking at the appointment time, I think, that you might have mentioned. I think that's something quite interesting to explore and see what work is going on, if any, already in that area, which I don't know.
Yeah, I think there's absolutely, yeah, so this is something, yeah, I'm not sure that there is any, but there have been various studies that have looked at changing models of care, haven't they, and bringing sort of multiple elements into that, consultations with patients with multiple long-term conditions, perhaps bringing in a pharmacist, like a medication review element, and so kind of running a nurse practitioner clinic in parallel with the clinicians and pharmacists, sort of like an integrated model of care.
Yeah, because it was interesting hearing how poorly set up model of care is currently for multiple long-term conditions, and sort of the changing need of the patients, and how it seems that it's not really being addressed enough. So I think that's quite an interesting area. But yeah, all in all, I think both of the talks were just really interesting, and thank you for them. So yeah, and I think moving forward through these workshops, it looks like there'll be some stuff coming out of value that we can work with. I know, thinking about my work with the PhD student Ellen, who I think is here today, I think there's some stuff that we need to think about around self-management, because I think in terms of research, I think sometimes it's a lot more advanced, the thinking around the research and then bridging that gap. And I think that's part of the purpose of these workshops. So I'm thinking we might extend our stakeholder involvement a little bit wider to get some more health professional perspectives and things. So I think that's quite interesting. So it's helped us already. Thank you.
Yeah, absolutely. I think that's the thing, isn't it? A lot of the things that we were hoping to discuss today, we've already kind of talked through at the end of each of the chats, and there's really insightful comments, some really great ideas. And as the sessions are recorded, something to look back on and reflect back on and consider as well. And yeah, as you say, as the series goes on, we've got some. Oh, Kieran says Pauline's got her hand up.
Oh yeah, I can't see any hands.
Yeah, I'm really interested in what you just said, Fiona. Was about thinking about the support group that I set up. I mean, that was way back early in the 2000s. And it was, if you give people permission to do something, so if you give them permission to come in and moan, that's what they'll do. But actually giving somebody permission to come in and actually forget their illnesses, you will still hear about their illnesses, but you will hear them from a different perspective. So I'm wondering if there has been any sort of reference or research done from that perspective, in actually, doing that, in bringing this multi long-term conditions together as a peer support group, and saying, right, come together, because now there's so many, we're not concentrating on one area or another, but just come together and talk. But let's talk positive talk. Let's talk, how can we talk positively about what you bring, and what can you do, not what you can't do, what can you do, what can you still do, and start to generate something within the community that starts to set a precedence. And tell us the speakers you want to come in. So just around the table here, we've got people that might come in and say, well, we can talk about X or Y or Z or Z or whatever. So long as we have the buy-in from an area, and again, whether it be in person or online, whatever anybody is comfortable with, it starts to generate something that, are people going to latch onto this? Or is it, either or, I suppose, isn't there? is it that people just want to live in that doom and gloom? Because actually, you know, I get more interest from that, because, you know, people go, oh, you know, oh, how are you today? You're looking really down in the dumps or whatever. Or I can get in to see Kate because she gives me, sorry, Kate, but you give me more attention. I get 20 minutes with you. Whereas if I've got nothing, I never see you. So there's, you know, there's all sorts of swings and roundabouts, but, you know, how do we address it? But I would like to start addressing from a positive point of view. So that's my thoughts. I know Socrates got her hand up as well.
Something interesting to explore for sure, I think. Yeah. Socrates. I can see hands, but I can't see who they're linked to.
I think Shukrat's got her hand up. Shukrat, is that right?
Sorry, it's just been clicking my mic on and off. It's just you know, we're talking about action points to think about, and I was just, as Kate mentioned, it would be really useful if, you know, we could contribute to reviewing the GP training curriculum somewhat, such that there is more awareness of, you know, the she used the phrase MLTC specific competencies, you know, that GPs should be aware of while they're in training, you know, so they're more in a headspace where they're prepared for meeting these challenges when they do start practice. So it's about how we can get the curriculum updated or reviewed to include these.
Yeah, absolutely. I think that's a really important point there, isn't it? It's about equipping, sort of incorporating that as part of training. And I think there are efforts underway now to look at that, not quite at GP training level yet, although there absolutely should be in the future. At the minute, I think actually Health Education East Midlands are running a generalism programme for their internal medicine trainees, or what were core medical trainees. And as part of that, there's going to be a multiple long-term conditions element. And yeah, and I think the idea is, if based on the success and learning points from that, it would hopefully be extended to GP training as well. But yeah, and also into undergraduate medical training, really, because as Kate pointed out, you know, it's that we don't really gain those skills of managing that complexity. And actually, I think the phrase was working at the edge of our comfort zones as well. Of, you know, we kind of what happens when you don't have a clear answer, what happens when you're trying to navigate multiple guidelines and apply it to whether everything's conflicting, and how do you sort of navigate that as the clinician. I think that's something that we've sort of learned on the job, really, up until now, isn't it? And I think it would be a really important element to incorporate, yeah, absolutely, as part of medical training. I'm sure you'd agree, Kate, and then any other clinicians that we had here.
Yes, definitely. I think it's really helpful to have all the different guidelines that we do have, but yeah, when they are in conflict, it's really tricky as to know how to manage that tension. And definitely, you know, in terms of medical education, you can understand that when someone's trying to build up their knowledge, it makes sense to start with individual conditions, because you've got to start somewhere and you've got those building blocks. But coming back round again, I think a really important higher level competency later in medical school is to understand the interplay between those conditions, because you're going to have that right from day one on the wards, in terms of, you know, very rarely going to encounter a patient who's just got one thing and nothing else modifying its effects.
Absolutely, and it's not a problem just for, like you say, it's not just a primary care issue, it's really across medicine now, isn't it? And there was that editorial where Chris Whitty wrote for a little while ago, a couple of years ago, for the BMJ, where he talks about actually now the skills of management, of the holistic skills required for managing multiple long-term conditions, even for doctors that specialise in a single disease area, even for them, it's still important to bear that in mind, to prevent that sort of fragmentation of care and promote that, you know, that holistic perspective. So yeah, thanks everybody. So is there, unless I think it looks like, so it's about 1:30 now. So so if has anybody else, is there anything else that anybody would like to raise or anybody would like to share, or any reflections or thoughts or any suggestions? Oh, Kieran's just posted there. Oh yes, so we've got our next session on the 1st of June. So as we mentioned at the beginning, this is actually part of a series of sessions where we're aiming to sort of bridge that gap between research and clinical practice in multiple long-term conditions. Our next session on the 1st of June, which is a Wednesday in 2 weeks' time, it's the same timings, 12 to 2, and really the focus for that session is around managing multiple long-term conditions and various perspectives on that. So from a self-management perspective, we've got Fion speaking, we've got a digital management element as well, and from myself on priority setting, which perhaps leads on nicely from the discussions that we've had today. And no, thank you very much, everybody. So so if everybody's happy and there's no further points to raise, then perhaps we can, we'll let everybody go, and if everybody's happy.